we have four main clinical pictures. So the first one is the first one, the earlier one, is the neonatal form, which usually starts at birth with epilepsy, a severe developmental delay, pyramidal and extrapyramidal signs, severe feeding difficulties, and often also obstructive hydrocephalus. Patients who present a little bit later, but before 2 years of age, usually present with developmental delay, macrocephaly, epilepsy, which can be also the presenting sign in some patients. The evolution is toward the spastic tetraparesis with or without cerebellar signs, and quite often also feeding disorders complicating all the clinical picture. So in general, in these two forms, the signs and symptoms related to a supratentorial involvement predominate the clinical picture, while in the other two subtypes, so the juvenile form and the adult form, the signs of involvement of subtentorial structure are more evident, such as dysphonia, dysarthria, dysphagia, anorexia, and so on, which really are the prominent signs in the adult form. So this classification was proposed in 1976 and it was enriched in 2000 by the description of the neonatal presentation. But the classification story is much longer. In 2011, two groups, one from the group of Yoshida and the group of Adeline van der Ver, proposed two different types of classification. The first one from the Yoshida group was this one. He distinguished three main forms. So a cerebral form predominated by signs and symptoms of supratentorial involvement, and which has onset usually in the pediatric age, and then a bulbospinal form in which signs of subtentorial involvement predominate. And then there are patients who present with this intermediate form who has signs mixed of the two other forms. At the same, during the same year, the group of Adeline van der Ver proposed this other classification. So they distinguished type 1 and type 2 Alexander disease, where type 1 is quite similar to the cerebral form of Yoshida classification, and type 2 is quite similar to the bulbospinal form of Yoshida group. We tried to work a little bit on this classification, and particularly we focused on the type 1 form, because we noticed that the clinical evolution over time of type 1 patient was quite different depending on the patient. And so we started looking on our Italian cohort of patients, and then we extended the study to a group of patients from literature, and we were able to identify four main trajectory of the clinical evolution of this condition. So we have patients affected with Alexander disease type 1A, which are characterized by a very early onset with a severe developmental delay, no postural acquisition, and usually death by the age of 2 years. And then we have patients who present a phenotype that we grouped as type 1B, in which patients have to present with developmental delay. They acquire some postural acquisition, but they do not acquire autonomous deambulation, and they start deteriorating before the age of 6 years. Patients affected presented with type 1C suffer from developmental delay, but they acquire autonomous deambulation even if with delay, and they start deteriorating between the age of 6 and 12 years of age. And then we have a milder presentation, which is named here type 1D. In this case, patients present with motor, but in some cases even only cognitive developmental delay. They acquired autonomous deambulation, sometimes at a regular age, and they remain stable beyond the beginning of adolescence. As you know, in recent years, a number of new drugs has been developed. One of them are antisense oligonucleotides, which are small nucleic acids that are able to modulate the expression and the function of mRNA. So this strategy has been tested in preclinical study for Alexander disease, and the results of the study on the animal models were quite promising, and this led to start this clinical trial, which is now ongoing. So we will have to wait some, I mean, the next future to see if this will be proven as efficacious or not. I would like just to share with you this new platform that has been recently developed. So if any one of you is interested to deepen more the knowledge on this condition, could go directly at this website. Astrocytes are very important also for inflammatory processes. They are able to produce interferon alpha, which is a cytokine that is normally produced to fight against viral infection. And there is a condition, which is Aicardi-Gouttière syndrome, which is related to an abnormal production of interferon alpha. It is a disorder which is due to a pathogenic variant in one of these 9 genes. This pathogenic variant leads to an abnormal accumulation or sensing to intracellular nucleic acids. So the cells think that these abnormal nucleic acids are of viral origin, and so it produces interferon alpha. But in viral illnesses, at the end of the infection, the production of interferon alpha stops. But in this case, in Aicardi-Gouttière syndrome, there is a chronic production of interferon alpha. This produces a cascade of events mediated by these kinases, which are called Janus kinases, that lead to a systemic inflammation that ultimately lead to the degeneration that is characteristic of this condition. From a clinical perspective, Aicardi-Gouttière patients usually present during the first year of life, in the majority of cases, with the neuromotor regression or stagnation, the appearance of pyramidal and extrapyramidal signs. They have an acquired microcephaly. It is a peculiar condition because we usually observe a first progressive phase, which is followed by a stabilization of the clinical picture. In this first active phase of the disease, which usually lasts some months, we can also observe a severe irritability, feeding disorders, sleep disorders, recurrent fever sine causa. And we can also have some systemic symptoms that you can see listed here. Neuroradiology, so MRI and NCD, can disclose the classic features of this condition, which are leukodystrophy, brain atrophy, and cerebral calcification, which are quite specific. From a biological perspective, we have some biomarkers that can help pointing to the diagnosis. So usually we found the chronic lymphocytosis on CSF. We have high concentration of interferon alpha of CSF, and we can find a positive interferon signature. And of course, the genetic analysis will give the final confirmation if we find a variant in one of the 9 genes so far described as cause of death. There are some treatments that are on study for this condition. The two major ones are antiretrovirals and JAK inhibitors. Particularly, JAK inhibitors are those who has been for which we had the longer experience. The most important publication is this one that show the results of a clinical trial that has been conducted on 35 patients, and which demonstrated is a significant efficacy on extraneurological signs. We had some doubt on the effects on the neurological part of the disease, and this is due to many possible cause. The most important one is probably the fact that it seems that these drugs have an inadequate penetration within the central nervous system. Antiretroviral are also on study. They have been used in this trial, and the results of this trial have been published in 2018, and they have been demonstrated quite efficacious on the biological markers of the disease, showing a reduction of them. This was a phase 1 study, so the primary outcome was based on the biological marker. And there are a number of other clinical trials that are now ongoing, and so we don't know the results yet. Another condition which is in the group of astrocytopathies is vanishing white matter. As we said, astrocytes are important for inflammatory processes, not only the production of interferon alpha, also the response to stressor agents. And also, they are very important to facilitate normal myelination. And these two functions are both impaired in vanishing white matter, which is an autosomal recessive condition due to mutation in one of the 5 genes encoding the subunits of eukaryotic initiation factor 2B. AF2B is very important to start the protein synthesis, but when we have during a stressor event, AF2B is inhibited, and this this lead to a reduction of the protein synthesis, which is a very important effect because it consents to save energy needed for other cellular processes. But in vanishing white matter, AF2B is chronically inactivated, and this ultimately leads to cell death. In this condition, the clinical presentation is characterized by onset at all ages, but most often between 2 years and 6 years of age. Usually, we observe a chronic motor and cognitive decline associated to episodes of rapid and severe decline in neurological function, usually provoked by physical stresses. There are also, for vanishing white matter disease, some clinical trials that are again ongoing, and so we will have to wait a bit to see the results. The last group of condition I want to mention is the last two conditions I want to mention are megalencephalic leukoencephalopathy with subcortical cyst, MLC, and CLCN2 related leukoencephalopathy, CC2L. The first one is due to mutation on one of these 4 genes, MLC1, GlialCAM, GPRC5P, or aquaporin-4, while the second one, CC2L, is due to mutation on CLCN2. All these genes are very important for another astrocyte's function, meaning the regulation of the extracellular environment. In fact, they are involved in all processes that regulate the homeostasis of ion and water within the the brain white matter. So if we have mutation in one of these genes, there is an accumulation of water leading to the formation of vacuoles, which are very large in MLC. So we have a macrovacuolization in MLC, or are quite small, or can be quite small in CC2. So in MLC, the clinical presentation is very early, with early onset macrocephaly, developmental delay, progressive ataxia with or without spasticity. There is a slowly progressive cognitive decline over time, and then we can also observe some very peculiar worsening, acute worsening of the clinical picture induced by head trauma or fever. We have actually two main different subtype. So B allelic mutation on MLC1, B allelic mutation of glial-CAM, or monoallelic mutation in GPRC5B leads to the classic phenotype that I just described, while monoallelic mutation in glial-CAM or B allelic mutation of aquaporin 4 cause a different subtype, which present quite similarly to the classic one, but have a very different clinical course, because these patients spontaneously improve on the clinical picture spontaneously improve, but also the MRI improve over time, becoming almost normal. While patients affected with CLCN2 related leukoencephalopathy present with a much more mild phenotype. Usually onset could be from infancy to adulthood, with mild cerebellar signs, sometimes even only a small intentional tremor. Mild spasticity can be associated usually in pediatric patients. Retinopathy and optic neuropathy can be observed, as also headaches, learning disability. The clinical course over time is quite stable, so we don't observe usually a significant progression of the signs and symptoms. There are some preclinical studies that suggest that gene therapy could be a promising therapeutic strategy for MLC, but we will have to wait also in this case in the future to see if it will be proven as efficacious or not. And with that, I really thank you for your attention, and I leave the floor to my colleague for the neurological part.
Okay, wonderful. Now it's time to shift from the clinical side of these conditions to the neuroradiological side. So it's my pleasure to see Cecilia Parazzini. And now, Cecilia, you can start with your presentation. And I see your screen, so don't worry, you can start.
Okay, thank you, Gennaro. Good afternoon, and thank you for the invitation. Now we go on with exploring the radiological pictures of this disease. And most of our knowledge is due to Dr. Mario van der Naap and her group. We focus mainly on the early onset of this disease, and I apologize if I tell you something that Dr. Tonduti has already told you. Astrocytopathies are a subgroup of leukodystrophy due to astrocyte dysfunction. Normally, astrocytes are essential in maintaining CNS iron-water homeostasis, preserving blood-brain CSF barriers, to regulate myelin development, and to respond to brain injury. And all these functions are altered in different way in the different type of astrocytopathies. These diseases share some neuropathological features such as white matter rarefaction, cystic degeneration, minimal astrogliosis, and increased numbers of oligodendrocyte progenitor cells that inhibit maturation to myelin-forming cells, explain the lack of myelination. And this is particularly true for Alexander disease, a vanishing white matter. So the damage begins in the astrocyte and then extends beyond, involving other cellular elements, and the resulting white matter degeneration and the neuronal loss. And all these features can be detected by MRI. Only a few words about the radiological technique and the imaging protocol that help us to define this white matter disease, to differentiate them from other pathologies, but also to monitor disease progression and eventual modification due to new therapeutic approach. A standard protocol should include T2-weighted sequences, T1-weighted sequences, also volumetric sequence, flare according to patient age, and this sequence is important, for example, to differentiate between cystic lesion and white matter rarefaction, diffusion, SWI, to look for classification, even if we know that the gold standard is CT scan, spectroscopy, and single voxel is usually enough, contrast medium in case of suspected lesions, and MR angiography in selected cases. Let's start with Alexander disease, that is a well-known disease, even if quite rare, due to mutation in a GFAP protein. This mutated protein forms cytoplasmic aggregates called rosenthal fibers that are the histopathological indicator of Alexander disease. And these aggregates are mainly detected in subependymal, subpier, and perivascular astrocytes that become swollen, and this explains some increase in thickness of some brain structures. And change in astrocyte morphology promote an inflammatory environment in the CNS with brain neurotoxicity. Many years ago, 5 MRI criteria were defined, but actually we know that not all patients fulfill all of them. They are symmetrical white matter abnormalities with frontal preponderance that initially sparing subcortical U fibers. So the deep periventricular area are involved before the subcortical fibers, with an anteroposterior gradient. Abnormalities of the basal ganglia and thalami, both with swelling or atrophy, brainstem and cerebellum abnormalities, mainly in the medulla, and also nodular contrast enhancement, lying ventricles, but also in frontal white matter and in other brain structures. Usually MRS spectroscopy is not specific and can show reduced NAA and increased choline due to axonal loss and increase of cellular membrane turnover. This patient present with macrocrania. This to underline how U fibers can be spared at the beginning of the disease, but also later in the course of the disease, U fibers can be not involved, mainly posteriorly. And another feature is a sort of a gyral swelling due to the swelling of white matter at the beginning of the disease. As in the other astrocytopathies, cyst formation is very frequent. In Alexander disease, cysts are mainly localized in the frontal white matter, differently from what we can see in other astrocytopathies. And sometimes they may be small, so it is important to have a good exam with good sequences and good playing. and they are localized mainly in subcortical, periventricular, on deep white matter. And in young patient, cyst may be more diffuse, huge and devastating. Alexander disease is divided in type 1 and type 2 according to clinical presentation, age of onset, and also radiological findings. And in type 1 are reflected the criteria, MRI criteria that we have seen before. So, as you can see in this case, white matter is involved, is swelling mainly in the frontal region with two fiber sparing posteriorly. Basal ganglia are swollen, and on diffusion we can have an increased diffusion of the involved white matter. There is a thickening of some structures such as fornix, hypothalamus, chiasma, and the quadrigeminal plate with consequent stenosis or substenosis of aqueduct and ventriculomegaly. And we can have also a nodular contrast enhancement in frontal white matter and fornix. Also, infratentorial structures are involved, but at the beginning of the disease, the involvement may be very subtle, so it's important to look for it. Medulla is primarily involved, mainly posteriorly and with a symmetrical way, but also white cerebellar white matter, mainly in the peridentate nuclei. To show you how at the beginning of the disease, basal ganglia may be swollen, but then they become atrophic. And here you can see also a progressive reduction of thalami volume that, and also increase in ventricular size due to a progressive atrophy. In type 2 Alexander disease, there is a predominant involvement of subtentorial white matter, mainly medulla, also in this case, and the cerebellar and peridentate area, while subtentorial white matter is less involved respect to type 1 Alexander disease. Typical features are present in neonatal form, in which white matter abnormalities is really important, and there is a congenital hydrocephalus due to aqueductal stenosis for increase in size of the tectum. And in some cases, as shown here, we can have also nodular enhancement of the quadrigeminal plate. Very few cases have been described of prenatal imaging of Alexander disease, and actually the diagnosis was made by genetical tests and neuropathological data. But in both these cases, typical feature is increasing thickness of chiasma and fornix. A very subtle periventricular white matter alteration have been described, but this is very difficult to be seen in a prenatal imaging. Megalencephalic leukoencephalopathy with subcortical cyst and CLCN2 disease are two other astrocytopathy with different genetical mutation, different radiological features, but that share the same pathophysiological mechanism. In MLC, there is a reduced expression of GLCAM MLC1 complex, while in CLCN2 we have a CLC2 chloride channel impairment, and both these factors are co-localized on perivascular astrocytes and produce an impairment of water-ion homeostasis pathway. The result is a vaporization of myelin in which vacuoles are lined with myelin, and leading to a intramyelinic edema. In MLC, the typical feature is a severe symmetric white matter involvement with swelling, cysts in the tips of the temporal lobes and in the frontoparietal subcortical areas. So in this case, subcortical and ear fibers are involved more than deep and periventricular white matter, and there is a relative sparing of compact white matter tract. Generally, no great matter abnormalities are present. Because in this case, white matter is really very edematous, we have a macrocrania very early in the course of the disease, generally within the first year of life. This is a macrocranic 3-year-old boy with important swelling of white matter, relative sparing of internal capsule and corpus callosum, and cystic area in the temporal lobe and the subcortical parietal area that are well detected on FLAIR imaging. On diffusion sequence, we have an increase of diffusion, and in the cystic area, the value is very close to that of CSF. In CLCN2 disease, that is a very rare form, there is a characteristic symmetric long white matter tract involvement in the internal capsule, corpus callosum, and cerebral peduncles, because the chloride channel are expressed mainly in this region. And on diffusion sequences, there is a variable reduction of diffusion due to intramyelinic edema due to microvacuolization of the myelin. You can see also an involvement of subtentorial areas such as middle cerebellar peduncles, cerebral peduncles, while hemispheric white matter is less involved, and the U fibers are spared also in this disease. As in the other astrocytopathy, little cysts may appear in the course of the disease. Vanishing white matter is one of the most common white matter disease in childhood, but also may appear in any age, and it's due to a mutation in EIF2B vector. And this mutation produces a deregulation of the stress response in astrocyte. So the results are scarce reactive gliosis, no glial scarring, and lack of myelin, because altered astrocyte produce an altered secretome that have a negative effect on maturation and function of oligodendrocyte. And this is a beautiful picture in which myelin sheath around an axon is thinner in a patient respect to a normal control. The classical radiological feature are a diffuse symmetric white matter involvement with deep periventricular white matter predominance, and the involved white matter is characterized by the hyperintensity close to that of CSF on FLAIR sequences due to rarefaction of white matter. Another typical feature is the presence of dot-like lesions in the axial plane and radiated lesion in the sagittal and coronal plane within the areas of CSF-like white matter called strip-like pattern or tigroid pattern. This feature is not specific only for this disease, but it is present in quite all patients. This is a case of in which we can see a rarefaction of white matter with tigroid pattern and cystic degeneration in the periventricular area. In very young patients, we can have a more diffuse involvement of white matters. Also, internal capsule may be involved. As you can see here, there is a typical tigroid pattern, and also infratentorial white matter, in particular cerebellar white matter and middle cerebellar pedunculus white matter is involved. Subtentorial white matter may have a less degeneration in cyst respect to supratentorial white matter. On brainstem, central tegmental tract are frequently involved, and also this aspect is not specific of this disease, but it's frequently present. You can see here how white matter is hypointense on FLAIR and T1 sequences, and the cyst formation in the temporal pool. In this pathology, we can have areas of increased diffusion in the area in which white matter is there is a rarefaction on cystic degeneration, but also area in which the diffusion is reduced, mainly in those areas in which myelination is already present at this age, and probably in this aspect have a correlation also with clinical worsening. We know that in vanishing white matter, there is a progressive derangement of the white matter that does not improve during the clinical recovery. But recently in this study performed on a huge number of patients, some transient lesions have been described in basal ganglia, thalami, and brainstem during clinical episode of worsening. And these lesions are mainly localized in thalami and pallidi and tend to disappear during clinical recovery. In fact, if you look at this graphic, MRI with abnormal score are lower before a clinical episode of worsening, but they become higher during the episode of or very close to the episode of clinical worsening. And this spontaneous improvement is important to be known, even if we want to test new therapeutic approach with MR imaging. And also it's important to remember that some of these diseases are quite new, so the exact pathophysiologic mechanism and natural history are not well known and understood yet. The last disease to discuss is Aicardi-Goutieres syndrome due to an aberrant production of interferon alpha. It's, as you have already heard, a very heterogeneous genetically disease. But the final mechanism is a failure in the protective mechanism for distinguishing self and non-self DNA and RNA. And this produces an activation of pro-inflammatory responses in astrocytes. Also, the radiological picture may be quite heterogeneous, but we can identify three particular features that are white matter abnormalities, intracranial calcification, and atrophy. White matter abnormalities is mainly in frontotemporal area, but actually white matter may be involved in more diffuse way with an asymmetric distribution, differently from what we have observed in the other form of astrocytosis. And in very young patients, we can see also delayed myelination followed by a progression of myelination over time. Then there are two particular radiological patterns with a very strong association with particular mutation. For example, we have intracranial large vessel abnormalities with SAM-HB1 and bilateral fatal necrosis with ADAR1. These patients are usually microcephalic. These are two cases with a classical form of AGS with diffuse involvement of white matter in a quite asymmetric manner. In the first case, you can see also a sort of atrophy with increase in size of subarachnoid spaces and ventricular system, and calcification in thalami, basal ganglia, and periventricular area. In the course of the disease, also in AGS, some little small cysts may appear, and this picture to show you how calcification may be present also in the cerebellum. This is a feature with a strong correlation with this mutation, in which a severe stenosis of intracranial vessel is evident, and consequent atrophic brain with gliosis and malachic lesion. And the other picture of a bilateral striatal necrosis associated to ADAR1 mutation. A spontaneous improvement of MRI findings have been described by our groups, but also by other groups, till a quite normal MRI picture. And this evolution cannot be completely explained by progression of myelination. So also in this case, it's very important to know the natural history of this disease. Also for AGS, prenatal diagnoses are described in few cases, and in all of them the diagnosis was made by genetical tests. But the most important markers may be microcephaly and UGR, and sometimes intracranial calcification. So the most important differential diagnosis is with congenital CMV infection. Of course, the clinical aspect, the biochemical and genetical tests may help us to make the right diagnosis. Only few take-home messages, coming back to one of the first slides that I show you. If you see diffuse white matter alteration and swelling, cystic degeneration, and minimal astrogliosis, think of astrocytopathies. But there are also some key radiological features that can help us to differentiate between the different types of astrocytopathies. For example, if you have a contrast enhancement and a thickening of some structures, think of Alexander disease. Subcortical cysts are typical of MLC. ADC reduction in a very packed, dense white matter tracts is typical feature of CLCN2 disease. Strip-like pattern, think of vanishing white matter, and calcification, think of AGS. Thank you for your attention.
Wonderful presentation, Cecilia, and wonderful even the previous presentation on the clinical aspect. I ask the audience if there are any comments or any questions for the faculty. Meanwhile, I would like to enhance and highlight the importance as a neuroradiologist to a rigorous protocol, and in fact I was so happy about one of your first slides, Cecilia, and even that we should not be harmful to use even CT to be sure regarding calcification. SWI is improving our protection, is helpful, but sometimes the old CT scan could be the game changer. I would like to have a comment by you regarding the useful of CT in certain cases.
Yes, if you are not sure that what you've seen in SWI are calcification, and then they have, it may happen, it's important to do CT scan. Mainly in those situations, if you have difficult to reach a diagnosis. So in any case of leukodystrophy, in which the diagnosis is not made, it's important to look for calcification, and so CT may be important in these cases.
Okay, wonderful. I see now one question. What are the radiological features of astrogliosis?
The radiological features, what are they?
I agree with you about the radiological features of astrogliosis. I suppose it's
more a pathological feature, astrogliosis, more than a radiological feature. So I think it's not very easy.
Okay, and I agree with you. So
Hyperintensity.
hyperintensity on T2.
Yes.
Oh, okay.
But
We
in
have
many of these
yeah.
cases, we have no astrogliosis. It's more easy to have a rarefaction and cystic degeneration of the white matter.
Okay.
So white matter with a signal similar to that of CSF in some cases.
Okay. I have the time for another questions from Eduardo Caverzasis. I was wondering about your experience and literature on the use of myelin-dedicated imaging in the study of these pathologies.
But in younger patients, we try to use T2 sequences with a higher TR in order to better define myelination, for example. But usually our protocol is quite standard with the sequences that I show you. So T2 and T1 with the correction of parameters according to the age of the patients.
Okay, wonderful. One last quick questions. Approximately how much percentage of subcortical U fibers involvement do we have in Alexander disease?
It depends if we are at the beginning of the disease at the end of the disease. Initially, U fiber are sparing, but in type 1, they become involved quite faster, mainly anteriorly.
It depends also on the age onset of the patient. So earlier onset presentation had an earlier involvement of U fibers, while it is much more, it is observed much more later in later onset forms.
Okay, I think that now we have to close because we are approaching the end of this webinar. I would ask to the faculty a final few words from both your side, clinical and radiological side, and to the for going to the end of this webinar, please. Davide, would you like to say some final words?
Remember the slides.
Yes. No, I can just remember you that there is this nice web page for Alexander disease, which contains a lot of information about the condition, so it's quite nice. And I just want to thank all of you for your attention.
Okay, can you remind the name of the website of the Alexander classification, please?
I don't know if I can share again my presentation.
I can give you the privilege. No, okay.
I will show you the slide where you can find all the. Just a second. Here it is.
Okay, wonderful. Okay, wonderful. Cecilia, would you like to say something?
I think that, as I told before, some of these diseases are not well known. Mainly their natural history is not clear. So, of course, it's important to concentrate these patients in order to study better them and their history, their imaging, their clinical progression.
Okay, wonderful. So I think that we can go to the conclusion. That is 5:30 p.m. Central European Time, and as usual, season greetings to everyone. Merry Christmas and Happy New Year for a wonderful 2025 for everyone. And remember that you will receive after the end of this webinar the evaluation form to receive the CME. And as usual, from Milan to the world, see you next time and bye-bye.
Bye. Thank you. Merry Christmas.